The next treatment for fractures would be traction. This helps with immobilizing the actual bone, setting it in the correct position, and also it aids the child who is having muscle spasms. We see this used a lot with leg fractures, specifically femoral fractures. It may be used to kind of maintain the alignment before we cast them, or in some cases, this is what we use to actually allow the bone to heal, and that would be balanced skeletal traction, where we put a pin through the bone itself. Different types of traction include skin traction, and that is usually like kind of a pulling force and weights on it to keep the limb in alignment. This is sometimes used prior to casting. Or we could do skeletal traction, as I mentioned before, which was the pins through the bones with free hanging weights to keep those bones in proper alignment. And also, some cases, depending on where the fracture is and what's going on, we may actually use a halo traction. And that is where you have a metal ring, kind of like a halo around the child's head, and there are pins that are screwed into, go into the skull, or all the way around to maintain, a lot of times you'll see it connected with bars to the shoulders to maintain neck alignment and stability. We use it sometimes with fractures of the neck. We see it used also with children who have high scoliosis curves. As far as interventions for a child who is in traction, probably the first thing we want to make sure is that they're in proper body alignment. In other words, if the limb, whatever it may be, an arm, leg, whatever, that it is perfectly straight. There's no twisting, there's no turning. We also want to make sure that if you have a child who is in balanced skeletal traction, in order for them to be able to move around well in the bed, they need to have a overhead trapeze that they can reach up and pull up on with their arms to move their body around in the bed. We want to also assess any pin sites in a child who has balanced skeletal traction to make sure there's no drainage, there's no breakdown around it, a redness oozing, anything like this. We're going to be doing pin site care once or twice a shift early on after they get the balanced skeletal traction applied. And how we do it is based upon the institution's protocols. But in most cases, what you're going to be using is something like some type of cleansing antiseptic type of cleanser on it. I've seen half-strength peroxide used. I've seen a variety of things used. But the key to it is cleaning that pin very, very well and removing all crust so that any drainage can come out. We don't want the crust to close up that canal with the pin going in because it does not allow drainage and you're going to get an infection in there. Always checking our 5 Ps, our neurovascular checks on the children, making sure that the weights in balanced skeletal traction, that the weights are free hanging, they're not on the bed, they're not on the floor, etc. If we find them like that, we contact the doctor and get him to come and assist with those. We don't mess with weights at all. Make sure we're providing appropriate pain relief, whether it's pharmacological or non-pharmacological for the children. Make sure we're maintaining good ROM on those uninvolved joints. So if it's a child with a fractured leg on the right, that left leg we're going to be doing exercises with. And don't forget the incentive spirometers or some other type of deep breathing exercise for the child, since they will be in bed and immobilized. We don't want them to end up with pneumonia. In this slide, I've simply given you some pictures of what I talk when I talk about traction, the different types. Upper right, you'll see a child that is actually has got a cast on the leg, and the leg is elevated up. On the top left, you see a little girl with a halo traction on. This is what I'm talking about, around the head, and there are actually screws. We have to be very careful that those screws do not move and cause gashes or cuts in the actual child's head. On the bottom, you can see that there is you got some balanced skeletal traction coming in, and the little guy in the yellow, and that's where you have the pins actually going through the bones. And then in this child on the right, it looks like they're actually using elevation in skin, so maybe some skin traction on this child. Some examples of fractions that you may see in kids, I just want to kind of give you a look. I'm a visual person, as you probably have figured out. On the top left, this actually shows a fracture prior to casting. You can see how swollen, and the bone is actually crooked, bruising you can see on that. In the middle, on the top, you can see where the bones have totally gone past each other. And this would be an x-ray of a compound fracture because you can actually see the bone coming out of the limb. And of course, the little boy on the top right is showing out casting. Below him would be our actual external fixators, which we use a lot of times when we are trying to stabilize a bone. That is not a traction, that's simply a stabilizer. The little boy, of course, on the bottom has got a cast on. And then in the middle, the little girl in her cute pinky outfit here is demonstrating the importance of doing crutch walking. We want to make sure that we are educating these kids on how to do crutch walking. Make them practice before we ever discharge them from the hospital. And then this I put in because it's so true. I'm talking about siblings, and she has no idea what happened to that child's leg, right? Yeah, right. Typical siblings. Our next topic is Duchenne's muscular dystrophy. And it's the most common type that we see in children, usually are diagnosed around ages 3 to 7. It is an X-linked inheritance, so we're going to see it basically in males and little boys. If a woman is a carrier, she may have some degree of Duchenne's muscular dystrophy, but will not reach the severity that it does with the boys because they have no other X to counterbalance the side effects. With a female who is a carrier, you may see muscle weakness, some muscle breakdown, but nothing like you're going to see in the little boys. We diagnose this basically through the history that the parents report and then doing EMGs and muscle biopsy. Because what we see is a child who is progressing nicely, 2 to 3 year old, but instead of their gross motor skills improving, they seem to plateau and then begin to go backward. They're tripping more, they're falling more, kind of have an unsteady gait, difficulty walking. And then what we begin to see is progressive muscle weakness, and then eventually heart and respiratory problems. And usually later, what causes death in these children is either cardiac or respiratory failure, just simply because of the muscles that are affected in this. As far as caring for a child who does have Duchenne's muscular dystrophy, it's imperative that we get genetic counseling for the mother and all her siblings, specifically the sisters, because if it was a male who had this, they would know this by now. We want to make sure we're monitoring the child's respiratory function, encouraging them to stay away from ill contacts at all times because they simply don't have the ability to fight upper respiratory tract infections like normal children. Encouraging them also to be physically active and independent as long as they possibly can. The average age for entering a wheelchair for these children is around 11 to 12 years of age, so we try to keep them mobile and on their own, walking as long as we possibly can. Don't forget the use of the incentive spirometers like we had mentioned previously with a child who is in skeletal traction. We want to make sure that they're using those respiratory muscles, and exercising and getting good respirations, opening those lungs up. Encouraging good nutrition, fluid intake for these children is also important. Making sure that they are all current on their immunizations. And as I mentioned, avoiding ill contacts. That doesn't mean the child cannot go to school because they can. But if you know there's a flu epidemic or some other thing is going through the classroom, it might be a good idea to keep them home. As far as medications, sometimes they use corticosteroids on them to help with the muscle strengthening. They may use bronchodilators on these kids to help with respirations and clearing out any secretions they may have. They also may use supplements such as vitamins and minerals, and of course antibiotics, PRN. They're going to give these children antibiotics probably quicker than they would regular children because they don't want to take a chance on the child developing pneumonia. Of course, complications is that there is no cure for Duchenne's muscular dystrophy. Eventually, these children will die. Usually, it is, like I said, cardiac or respiratory failure. And ages, though, these children are living much, much longer because we are much better at managing them. Most MD kids are now dying in early adulthood. Their 20s, somewhere in there, is the average age for their lifespan. So the unfortunate part is sometimes parents have more than one Duchenne's child because by the time they realize the oldest one was diagnosed, they've had another child.